So my freshman year of college, I decided I wanted to be a lawyer. And to test this hypothesis, I signed up for an internship in the housing unit at Greater Boston Legal Services. Show up my first day on the job, totally prepared to make photocopies and coffee, all the things I'm qualified to do as a 17-year-old. And end up working for this completely crazy, deeply inspired lawyer named Jeff Purcell, who thrust me onto the front lines from the very first day. So over the course of 9 months, I had the opportunity to have dozens and dozens of conversations with low-income families in Boston about the real issues they were facing. And the families would come in and present with housing issues, because we were a housing unit. But whenever you scratched the surface, there was always an underlying health issue. So for example, one of my clients came in, he's about to be evicted, hasn't paid his rent, and I said to him, if you don't pay your rent, you're probably going to be evicted. And he said, I'm paying for my HIV medication. And that seemed like the right choice to me. One of my clients was a mother who came in, her child had asthma, and woke up every morning covered in cockroaches. And over the course of these 9 months, I just grew fixated on this connection between health and poverty, and really at the same time incredibly frustrated with intervening so far downstream. By the time families came to us, they were in crisis, and it was frankly in most cases too late. So at the end of my freshman year of college, I read an article in the Boston Globe magazine about the work that Barry Zuckerman was doing as chair of pediatrics at what was then Boston City Hospital, now Boston Medical Center. And the article talked about how Barry had this kind of radical but totally obvious vision that a pediatrics department should be a place where kids actually get healthy. And to realize this vision, he had assembled a dream team of professionals to go way beyond traditional clinical care. He had brought lawyers into the department, grief counselors because so many of the kids had witnessed domestic or community violence, developmental psychologists, a total dream team. And this resonated powerfully based on my experience at Legal Services. So at the start of my sophomore year, I called up Barry and congratulated him on his good work and told him that I thought that there could be an important role for young people to play. And with Barry's blessing, I ended up spending about 6 months just wandering through the halls of the hospital and really just attaching myself to physicians, in the cafeteria or in the patient rooms or in the ER on Friday nights. And with no medical training to speak of or public health training, I would just say to them, if you had unlimited resources, what's the one thing you would give your patients? And in these almost kind of confessional tones, they would say again and again the same thing. They would say, every day, Rebecca, we have patients who come into the clinic, kid has an ear infection or an asthma exacerbation, and I prescribe antibiotics or an inhaler. But I know that the real issue is that there's no food at home. I know that the real issue is that this family is living in a car. And they would say, even though I know those factors will have a more profound impact on the health of my patients than anything I'm probably going to do in the next 13 minutes in the 4 walls of the doctor's office, I don't even ask about those issues because I have no idea where to begin. I have limited time with my patients. The patients are piling up in the waiting room. I have no idea where the nearest food pantry is. I wasn't trained to do this. I don't even ask. And I've had doctors since then say, for those issues, we practice a don't ask, don't tell policy. Some of the doctors would say to me, if I can, I take $20 out of my wallet and give it to my patients. And I remember thinking, I don't know anything about the healthcare system, but this is not a system. This is total chaos. And so Project Health's Family Help Desk program was born of those conversations. The Family Help Desk is a physical desk in the clinic waiting room. This one is at Hasbro Hospital in Rhode Island. And when low-income patients come into the clinic and the physician or nurse or other healthcare provider identifies any unmet resource need that will have a negative impact on the health of the patient, so access to food, housing, childcare, job training, exercise programs, the healthcare provider can literally take out a prescription pad, that's our prescription pad, and can prescribe food or prescribe housing right alongside the medication. The family will then take the prescription to the desk in the waiting room, the same way they take a regular prescription to the pharmacy. And our team of college volunteers there at the Family Help Desk will work both on-site in the clinic and through ongoing follow-up to connect that patient to whatever set of resources that he or she needs to be healthy. And the most important part in some ways is that in addition, the volunteer will then communicate back to the provider what actually happened with the family. Did they get the food? Is the food stamps application pending? And in many of our clinics, we're actually able to have the volunteers have direct access to electronic medical record. And they'll go in and not only record their interaction with the patient, but create a flag for the provider. So next time the patient comes in, the doctor knows to ask whether their housing situation has been resolved or they've finally gotten the food that they need. So before we go any further, I wanted to pause on this point about the college volunteers, because I'm sure that many, if not most of you, are thinking, really? College volunteers? Aren't they sort of flaky and totally irresponsible? And the thing is, it's a legitimate question, because the reality is most college community service is, for lack of a better word, kind of crap. It doesn't actually work that well. And in fact, this was one of the things that really motivated me in starting Project Health. There were these posters on campus that killed me. They would say, you know, come tutor a child, it's only 2 hours a week, the kids come to campus, and it was kind of like if you read the fine print, it almost said, you know, we promise you this will be an inconsequential experience, but it'll look really good when you apply for med school. And it just felt like that couldn't be good enough. So what's interesting is there's actually another model of college volunteerism, and it's college sports teams. So college sports teams take a different approach, right? For college sports teams, they say, you probably won't even be good enough to make it on the team. You're gonna show up and there's gonna be 40 guys ahead of you in line for your spot, right? Practice is gonna be 6 days a week at 6 a.m. on some muddy field way across campus. This is gonna be a huge time commitment. It probably will jeopardize your studies. And if you don't perform, if you don't actually score, we're gonna kick you off the team. But at the same time, we will make deep investments in your leadership potential and your talent. And Project Health takes a similar approach. So we recruit competitively. About 10 to 30% of students get accepted in any given application cycle. We train intensively. They go through 18 hours of training before they even set foot in the clinic. We track their progress and collect data about their performance, and we make deep investments in them and their leadership potential. And in fact, there's certain competitive advantages to using college volunteers in the healthcare system. So the first is they are incredibly tenacious. As we like to say, our volunteers don't take no for an answer and have what we call a healthy disregard for red tape. And that, as you can imagine, in the healthcare system is a critical asset. The second thing is they're not just tech savvy, they are tech hungry. They're constantly outbeating our own systems, however good they are. And we often talk about that one of the core competencies of college volunteers is Google. Their ability to track down information is just unprecedented, and that's exactly what low-income patients and their families and healthcare providers need. And then the third thing is, of course, critical, is that they're very cheap. But so just in case you don't believe all the hype, I asked Sonia Sarkar today to join me today. Sonia was one of the founding volunteers for our site in Baltimore, which launched in 2006 and is now my chief of staff.
Thank you. So I remember the first time that I walked into Johns Hopkins Hospital, it was truly like being a kid in a huge candy store. I had never seen a place where healthcare happened so quickly and at such high quality. But every day when I walked out of the hospital doors and into the surrounding neighborhood of East Baltimore, all I ever heard was how desperate the health situation was in the city. In class, I learned statistic after statistic that placed the infant mortality rate in Baltimore at double that of the national average, and also learned that the life expectancy in Poppleton, which is a West Baltimore neighborhood just minutes away from the hospital, is less than the average life expectancy in Bangladesh. And it was then that I realized that despite access to an amazing institution and care from an amazing team of healthcare professionals, something clearly wasn't working. So when Project Health came to Baltimore in the fall of my sophomore year, I jumped at the chance to be a part of the solution to fill that infrastructure deficit. And I began volunteering at the Harriet Lane Clinic, which is a pediatric outpatient clinic at the hospital. And I remember very distinctly, it was a cold, brutal November day in Baltimore. And I saw one of my very first clients. She was a young mother, and she had just been in the ER all of the previous night for the third time that month because her son was suffering from asthma attacks. And she had come in the next day to talk with her pediatrician, who was a second-year resident at the clinic. And during the course of their conversation, it surfaced that she didn't have the ability to put enough food on the table at the end of the month. So the doctor did two things. She wrote a prescription for an asthma inhaler for the son, and then she wrote a prescription for food and walked the family over to me at the family help desk. And I remember what stood out for me the most was how extremely exhausted this young mother looked. At the time, she couldn't have been more than a few years older than I was. And we started talking, and she started telling me her life story. And it turned out that she and her 3 young children lived in an old, dilapidated Baltimore row home with 11 other people. It was a house with, lead paint peeling off the walls, asbestos dust on the floor. She was working 2 part-time jobs, neither of which actually provided her with any health insurance benefits that she could apply to her kids, and was at risk for losing one, if not both of the jobs, because she was constantly having to ask coworkers to cover shifts for her so that she could take her kids to the doctor. And I remember her just looking up at me and saying, "Look, I just want a house that is actually a home and that will stop killing my kids." And in that moment, health and poverty weren't just 2 abstract buzzwords anymore. It was personal. It was deeply personal. And even though I knew that it was going to be an incredibly daunting task, I wanted nothing more in that moment than to just roll up my sleeves and get in there and work in tandem with my client to actually ensure that she was able to provide a better life for her kids. So we started simple, and we enrolled the children in MCHIP, which was Maryland's Medicaid program for kids at the time. As a result, the mom was able to enroll in medical assistance for families, so they weren't facing exorbitant ER bills anymore, which is great. We also enrolled the mom in a city-sponsored job training program, and she was able to keep a part-time job, but the program, if she completed a successful 3 months, ensured a placement at the end. And then we enrolled the family in food stamps so that they had at least a little bit more dispensable income to spend on nutritious food. And little by little, the family's freedom to spend money in the way that they wanted began to increase month by month. And about 6 months later, the family came back into the clinic for a well child care visit. And the family came over to me, and the young mom was ecstatic. She was waving. She said, I finally saved up enough to be able to pay a slightly higher rent every month, nothing dramatic, but it allowed them to move out of their old home and into a brand new neighborhood with safer housing and no longer any lead paint on the walls. And she said, I just want to thank you for allowing me to do this. And it was then that I realized that all of the pieces had already been there. All I had done was act as a connector and give the family a small boost, but all I had done was enable them to use the healthcare system that already existed around them. And for me, it was a truly transformational experience. I realized that the family was not only on the pathway to better health, but also on the pathway to a better life. So since then, healthcare has never looked the same for me. I and my fellow alumni and peers that have gone through the Project Health program, we're not even able to walk into a clinic without asking, where are the resource connections? What do you do about social determinants of health? And it's truly extraordinary what that kind of experience can do, especially for college students as they're going through this transformative stage in their careers and their lives. So it's now obviously my life's work, and it's been an incredible journey.
So this year, almost 800 Project Health volunteers in 6 cities and 20 different clinics will be working to connect nearly 18,000 children and adults with the resources they need to be healthy. But Project Health's commitment is not merely to actually increasing the number of children and families we serve, but to actually changing the healthcare system itself. So, the discussion about healthcare these days focuses, of course, mostly on access to care and quality of care, which are completely critical, absolutely necessary, but also not sufficient. And if we are to be serious about actually improving health outcomes and reducing healthcare costs, we have to begin to tackle the social determinants of health. And in fact, it's well documented in the medical literature that access to basic resources like food and housing directly impacts not only health outcomes, but also health care costs. And for example, a child who is less than 3 years old, whose family needs but doesn't receive heating assistance or utilities assistance, is 30% more likely to be hospitalized. And the challenge, of course, is that the infrastructure simply doesn't exist in the healthcare system to actually address these needs. So Project Health, for example, is in a clinic that has 47,000 patients and 1 social worker on hand. And this is totally typical. There is a massive infrastructure deficit in the clinics in this country. We're in a clinic on the south side of Chicago that has 79,000 patient visits a year and 1 social worker on staff. And what we envision is a healthcare system in which healthcare delivery isn't just about, of course, healthcare, but actually addresses patients' unmet resource needs as a standard part of patient care. And in particular, our goal is a healthcare system in which 100% of clinics that are serving low-income families are screening 100% of patients for unmet resource needs and connecting all patients with those needs to the resources that they need to be healthy. And I'll just say in closing that the discussion about healthcare these days is that the healthcare system is a disaster. It's expensive, it's bureaucratic, it's complicated, and we at Project Health believe that things can be different. Our model is simple, it's effective, it's cheap. And what we have found is by deploying college volunteers into clinics across the country, not only are we able to increase the capacity of those clinics to address the real needs their patients face and empower physicians and other healthcare providers to actually ask these questions of their patients, but to create also a new generation of leaders that have the tenacity, the conviction, and the experience to imagine a new kind of healthcare delivery. Thank you.